Kia ora tātou, no mai haere mai to our Goodfellow webinar on rheumatic fever and the follow-up in children and adults. In this webinar, our panel will cover a range of topics relating to rheumatic fever in the community and how to manage children and adults using case examples where relevant. My name is Katie McCulloch and I'm a nurse practitioner who works for the Goodfellow unit and in primary healthcare out in South Auckland. And tonight we're going to be hearing from Nigel Wilson, a paediatric infectious diseases physician working across the University of Auckland, Starship and KidzFirst hospitals. Her clinical work includes the care and management of children with rheumatic fever in hospital and outpatient clinics. And she's involved with rheumatic fever research, including studies of disease burden, pathogenesis and treatment. Simon Briggs is an adult infectious disease physician at Auckland Hospital. He's been involved in the care with adults with rheumatic fever for approximately 25 years. Nigel Wilson is a consultant paediatric cardiologist from Starship Child Health with 30 years of clinical research in echocardiography in acute rheumatic fever and rheumatic heart disease. Belinda Paku is the rheumatic fever clinical nurse specialist for Counties Manukau, who works predominantly in the community managing the secondary prophylaxis service. Mary Ann Ross is one of the cardiology nurse specialists and works in rheumatic fever and rheumatic heart disease services at Auckland DHB. And we'll also be joined tonight for the Q&A by Miriam Wheeler. And she is an adult cardiologist at Auckland Hospital with an interest in rheumatic heart disease, previously having worked in the Northern Territory, Australia, Sudan, and the Pacific Islands. I'll now hand over to Dr. Rachel Webb.
Kia ora tātou, and thank you very much, Katie, for that introduction. It's a pleasure to be here with a great multidisciplinary team tonight of rheumatic fever clinicians from around the Auckland region. In the room with me, I've got Mary Ann Ross and Belinda Paku, and on the screen, Nigel and Miriam, who will join us for the panel towards the end of the session. Rheumatic fever and its long-term sequelae chronic rheumatic heart disease are conditions which need little introduction in Aotearoa, New Zealand. What we know is that rheumatic fever is a childhood infection and leads to chronic disease impacts across the lifespan. So it really is a very challenging disease. And this level of challenge is heightened by the fact that the only effective treatment for this condition consists of intramuscular benzodiazepine penicillin injections every 28 or 21 days. And this is a treatment really that's been not advanced since the 1970s. We know that the causative pathway from group A streptococcal infection in the pharynx through to chronic valvular heart disease is actually very complex, with poorly understood immune dysregulation between the strep A infection and rheumatic fever phase, and then progression in some individuals to chronic valvular disease. Our approach to the prevention and control of rheumatic heart disease, some of you may be familiar with, but spans thinking about the underlying social and economic determinants of health which drive group A strep infections in our community, the appropriate treatment of group A streptococcal throat infections through primary prevention initiatives, and the New Zealand Rheumatic Fever Prevention Program running between 2012 and 2017 really exemplified intensive primary prevention. And then secondary prevention, which is the early diagnosis and appropriate management of rheumatic fever cases and delivery of benzodiazepine to prevent recurrences, through to tertiary interventions focused on managing severe valvular heart disease. And so the focus of most of our talk this evening will be around the secondary prevention and tertiary aspects. This slide highlights what many of us will be familiar with, is that in the last 2 decades, there's really been little positive impact in terms of rheumatic fever incidents in our country. In fact, we've seen steady increases in rheumatic fever rates with widening disparities, particularly affecting Pacific peoples, and a more flattened pattern among Māori, but very minimal disease amongst New Zealand European peoples and those from other ethnic groups. And this was despite the primary prevention program happening during this period. There was a drop, but not a sustained reduction. What does rheumatic fever look like in the Auckland region? I'm aware that some people on tonight's webinar will be practicing clinicians in South Auckland, but others will be joining us from around the country. South Auckland, where Belinda and I work, has the biggest rheumatic fever program in Aotearoa, New Zealand, and we have approximately 750 people on our secondary prophylaxis delivery program out in the community. When we think of rheumatic fever, we think of childhood hospitalisation events, but actually, as this graph on the right shows, the majority of people on the benzophen program are in fact adolescents and adults in the young adult to mid-adulthood age range. And that means pregnant women, mothers, young adults leading very busy, active lives. Important to note that a good proportion of people actually live in a household where there is more than one affected household or whānau member, really highlighting that this is a disease that affects whole families, and that we need to be offering wraparound housing and healthcare and ideally early case detection services to households affected by rheumatic fever. In County Manukau, there are over 350 people who have had adult valvular heart disease surgery, and most of these are in the older age group and still on prophylaxis because of the severity of their heart involvement. In terms of the care package that we deliver, we're fortunate to have a monthly multidisciplinary rheumatic fever and rheumatic heart disease clinic run at the Manukau Super Clinic, where there are a mixture of adult and paediatric clinicians, a dentist, access to social work and expert nursing and community worker support. There is also, through the adult cardiology service, a valvular heart disease specific clinic, and this includes a nurse-led clinic program. Cardiosurgical care is provided by our colleagues at Auckland District Health Board, both through the adult cardiosurgical services and the paediatric and congenital cardiac services team at Starship. And as well as our clinic, there is a monthly complex case review meeting held to discuss challenging cases. So that's a bit of a snapshot. I'm going to hand over now to Dr. Nigel Wilson, who has a pre-recorded talk which highlights some important paediatric presentations of rheumatic fever and rheumatic heart disease.
Kia ora koutou. I'm Nigel Wilson. It's a pleasure to be asked to talk to you today about acute rheumatic fever, mainly in childhood, but I will cover some aspects of chronic rheumatic heart disease. So my first case is a 10-year-old Samoan girl who presents to you. There's a history that she's actually had bilateral ankle pain. It started on the left and that went away. She took may have taken some Brufen, but then now the right ankle is really quite sore. She can't weight bear. You can see it there, it's red and it's swollen. You take her temperature. And so quite correctly, you wonder if she's got a septic arthritis, and you send her into hospital and the orthopedic team aspirate the joint and there's no pus. So the physicians get involved and in the workup, their inflammatory markers are elevated as there, prolonged PR interval. The next day, her streptococcal serology comes back with high titers. An echocardiogram was performed, and this shows mild mitral regurgitation. So of course, putting it all together, there's a history now of migratory bilateral arthritis. She's got carditis on the echocardiogram. She's got other features, but importantly, evidence of a preceding group A strep infection. So this is classical acute rheumatic fever, and it's actually fairly straightforward when it's that easy. If you look at our guidelines in 2014, there was a nice paper that had been published comparing septic arthritis to rheumatic fever. And you can see the actual age of septic arthritis is much younger at 5 years. And the rheumatic fever mean age 10 years. And interestingly, much higher inflammatory markers in the rheumatic fever group. And some of the monoarthritis of the rheumatic fever group had received non-steroidals, but the majority hadn't. If you go back to Duckett-Jones, and this was, of course, the famous Dr. Jones with the Jones criteria, he actually used arthralgia as a major manifestation. And then later the Americans demoted it to a minor criteria in the interest of specificity. So arthritis is a major manifestation. When it's classical, it's polyarthritis, often asymmetrical, and it's going to be there in 75 to even 90% of cases. That's why they present rheumatic fever. And often it's easy, it's in the large joints, ankles, knees, elbows, wrists. It's exquisitely sensitive to aspirin and non-steroidals, but it can affect the small joints. And in fact, any pattern of joints we've seen over the years. And so when the joints are atypical, we run through a list like this, again from the guidelines, and we'll run a battery of viral arthropathy and all those cytomegalo, Epstein-Barr, mycoplasma. We've seen all these mimicking rheumatic fever. So one of the main points about ARF diagnosis is often the symptoms don't seem that serious. They may not or may not present. And when they do, you've got to listen carefully for any child in Aotearoa who has got arthritis, especially if they're Māori or Pacific. And if you haven't seen rheumatic fever, some of you won't see many, especially in the South Island, but you've got to think of the illness. And so the trick is really to admit to hospital, could this child have rheumatic fever, refer them in for investigations. Of course, just you remember the Jones criteria. The important ones are polyarthritis and carditis. Sydenham's career, I think Rachel may have talked about that or in discussion. I'll briefly talk about erythema marginatum and subcutaneous nodules. And the minors, polyarthralgia, prolonged PR interval, raised inflammatory markers, and fever. But so important is this evidence of a preceding group A strep infection. And the Americans describe well, and we use the level of evidence because strep in the throat may not be an active infection. The more reliable evidence is elevated streptococcal titers, higher evidence than a throat isolate or a history of a sore throat. I'll just put some subcutaneous nodules in here. They're not that common, but if you look for them, they're reasonably specific. But there they are here. They're round, firm, painless, often over the elbows, wrists, knees, and ankles. There's one on the flexor surface of one of the top picture. But you're not going to see a lump and say, oh, this is rheumatic fever. It's really when you've got arthritis or carditis. And erythema marginatum, again, hard to see in dark-skinned individuals, but it's occurring reasonably. If you keep watching, you might see it. I mean, watching as in over days. It's serpiginous, flat, they're not itchy. And again, we're not going to diagnose that as a sole manifestation without carditis or arthritis. So carditis, obviously clinical carditis, evidence of mitral regurgitation or aortic regurgitation. And since the advent of echocardiography, we recognize subclinical carditis. So this is a picture here of left atrium, the anterior leaflet of the mitral valve, and this blue mosaic of mild mitral regurgitation, which you just won't hear even under good listening conditions. But this is pathological and abnormal. And we've spent quite a lot of time in the 90s working out the criteria that differentiated pathological from physiological valvulitis. And so in our setting, we would see about half the cases of ARF have clinical carditis, and you can hear the murmurs, but another 30%, you can't hear them. And it took a lot of persuading for the Americans because they were more worried about specificity rather than sensitivity. But all countries recognize subclinical carditis. And now in the 2015 AHA, the Jones criteria do accept subclinical carditis. And echocardiography is actually just pivotal in evaluating carditis of ARF. My second case is a 14-year-old Maori girl who was breathless walking home from school. She comes to see you, and there's a vague history of maybe her fingers have been sore in the last few weeks, not particularly swollen. And you think you can hear a murmur at the apex. So this is not normal to be breathless. So you send her in for a chest x-ray, wonder if she's got a chest infection. Can't hear too much in the lungs. Some other differentials there. Note she's got a bit of a wide pulse pressure, 102 or 45. Now we've got this left atrium, which is big. We've got a much broader jet of mitral regurgitation. It's moderate to severe. And then at the top, the mosaic at the top is the aortic regurgitation. So she's got aortic and mitral regurgitation. Her inflammatory markers were elevated. Again, streptococcal tetanus elevated. So the management is hospitalization, rest. Most of those children with acute rheumatic fever with good going carditis, more severe, will respond to diuretics. We don't have great immunomodulator treatment. We're working on trying to develop this. And if we don't settle, symptoms don't settle, then we're looking at cardiac surgery. So the evidence for cardiac surgery we've developed here at Greenland Hospital and now Starship Hospital, because there aren't many centres that have large numbers of acute rheumatic fever in childhood. But those are our guidelines there, continued symptoms and big ventricles for age. The adults, of course, have huge evidence-based medicine to help guide surgery for mitral regurgitation, aortic regurgitation or mitral stenosis. And because the American Heart Association, the American College, and the European societies, cardiac societies, produce every few years guidance on valvular heart disease. And rheumatic heart disease is no different in terms of criteria for surgery. And the last recommendation was in 2020. So just some words on best practice rheumatic heart disease care. Secondary prevention is going to be well covered in the later talks today. But the principle of best practice rheumatic heart disease care is really experienced review by a specialist who understands rheumatic heart disease with whatever their background is, but also pivotal is access to serial left ventricular function and valve function through echo. So echo is pivotal. The more severe disease, the more frequent you need to be seen. Obviously, monitoring anticoagulation if someone's got atrial fibrillation or mechanical prosthetic valve. Access to regular dental health care, because the risk of endocarditis is very significant on severe rheumatic heart disease, and a timely referral for rheumatic heart surgery. One of the questions we got asked to talk about from the unit was a child with an incidental heart murmur. So here's a hypothetical case. Child presents with a rash, and you just noted that your colleague a year ago had heard a heart murmur, so you think you have a listen. What's the feature of an innocent murmur? It's obviously a normal history, normal cardiovascular examination of pulses, blood pressure, precordium, normal heart sounds, systolic murmur, which varies with posture. So, you know, you might be confident, you might not be to dismiss that as innocent, but you might get a pediatrician to have a listen and see what they think. But let's just change it now to a Samoan boy who's 11-year-old. And then when you go through the history, it's just maybe he turned up in casualty 2 years ago with a sore knee and was sent home. Could this have been missed rheumatic fever? And then, or another child who's got a father with rheumatic heart disease. with a prosthetic valve. So this murmur, which seems innocent, this is a large framed 11-year-old, and you know, you're not quite so sure about your auscultation. Could you be missing a murmur? Or another example, you hear a blowing murmur at the apex, or you hear a diastolic murmur. So yes, this is completely different. You've now got a high index of suspicion that this, and you need to exclude chronic rheumatic heart disease. So yes, you're going to refer and you're going to demand an echo in your referral. So one of the, primary prevention, which we'll be talking about at times today, it's been difficult to reduce ARF rates, but one of the things that has really helped has been the health literacy has increased, because it's an unusual, difficult concept, isn't it? Why should a family understand that if you get a simple sore throat, that you're at risk of heart problems? And so historically, that health literacy has been low, but we, part of a study published in 2017, we found, in fact, health literacy has really increased in Maori and Pacific, 70 or 80%, recognizing this link. And then Michael Baker's recent case control study, 90%. So it's really good that whānau are asking questions, asking to be seen, asking to be referred. Has my child got rheumatic fever? The scene has changed a lot, which is really good. So thanks for your listening today. Thanks.
Good evening, my name's Marianne. I'm the rheumatic heart disease nurse specialist at Auckland City Hospital, and I do some work in Starship as well. So I'm going to talk about what is secondary prophylaxis. So just go to the next screen. So secondary prophylaxis is, we know, is the cornerstone of management of both preventing rheumatic fever and reducing the risk of further rheumatic heart disease. It's very effective, but it is actually the only treatment we have in preventing the streptococcal infection of the throat, which then reduces the risk of getting another rheumatic fever episode. And it also reduces the risk of further valve disease. So if we prevent the actual streptococcus infection in the first place, then it's very likely that we're not going to get any further disease progression. It's a medication that's done intramuscularly. It's every 28 days. It's a particular benzathine benzyl penicillin, which is a long-acting medication, and it's done IM in the BG site, which we're going to talk through shortly. And if usually it is 28 days, but if the child or the person develops group A streptococcal infection, even when they are taking their bicillin every 28 days, then we can reduce it to 21 days, but it's quite unusual. The duration for it is at least 10 years. So if we have a child who's, say, 13 years old, then, and it's going to be until they're 23, so it's for 10 years. Or if you have a child that's maybe only 6 years old, then we're still going to do it until they're at least 21 years old. So it's whichever is the longest. So even if you have a person who comes in that maybe has had a recurrent rheumatic fever episode and they're 21 years old, then we'll do it until they're 31 years old. However, if they're a person that does have severe rheumatic heart disease, or usually even moderate rheumatic heart disease, or they've had surgery for that heart valve disease, then we would usually keep them on longer. So we've got a chart coming up, but definitely people like young mothers that have, young children that are out in the school or the daycares, and they are more likely to bring home a streptococcal infection and put the mum at risk who's already had a rheumatic fever history, then we will usually keep her on the bicillin injection plan until she's a bit older and the kids are older. So it's the only effective treatment that we have at the moment to reduce this. So this is a chart from the Heart Foundation, and it's a little bit busy, sorry, but it does show you the length of time that we would, that's the guidelines for prophylaxis. So for established rheumatic heart disease, you can see that someone who's got mild or no or mild carditis and they're over 21, we would possibly consider 5 years, but actually we usually do 10. And aged under 21, definitely for 10 years or until they're 21, whichever is the longest. And then the moderate carditis, at least for 10 years or until age 30. And that also, of course, depends on if the disease severity gets worse, then we would keep them on longer. And usually when we do, when they get to the age of 21, then we also will want to do an echo just to make sure that they haven't had any further progression during that time on prophylaxis. And then we'll look to see if that's appropriate. If they had severe carditis, then definitely we would keep them on longer, and we would be doing regular echoes every 6 to 12 months anyway. So that is a kind of a conversation to have when they get older. And it really depends on if they're still at risk. So we might have a childcare teacher or a primary school teacher that maybe has severe carditis. We may keep them on longer than that if they're at risk of having a contact with a lot of strep. And possible ARF, if it's just we haven't aren't really sure, but we think that it was a rheumatic fever episode, as Rachel, and you can see with Nigel, it is quite a complex disease. So we'll put them on for 5 years with regular reviews. So this is the Heart Foundation guidelines just with regard to the antibiotic regime. So I think a majority of our children and adults are all on the benzathine penicillin. It's very rare that we have a problem with the benzathine penicillin, but if we do, then we would put them on the erythromycin, but unfortunately that's an oral medication that needs to be taken daily. So usually we always try and put them on the benzathine penicillin program. And if they do have a history of penicillin allergies, then we can refer them to immunology just to follow that up so we can then progress to benzathine.
Kia ora, I'm Belinda, clinical nurse specialist for Counties Manukau, mainly in the community. So I'll just go through a little bit about what happens with our service that we offer in counties and regionally with Auckland and Waitemata. It is registered nurses made up of public health nurses and district nurses who provide a free service to anyone with a diagnosis of rheumatic fever. And this is available for both children and adults. And I'll put there in most DHB, South Island have things differently set up because of the minimal numbers that they have. So typically in the Auckland region, that's how it's run up here. We offer a 7-day service. We're mobile, which means it's access to care for patients in whānau. And we visit them at home, school, work. We have nurses' clinics, so we try and make it easy for access for our patients. We have a really good recall system and reminder system that we actually remind our patients every 28 days or 21, depending, that their injections are due and book them in, and we record their bicyclin adherence, so we have a really good way of tracking that as well. We also, as part of our care, we provide monitoring of the INR levels and liaise closely with our GPs so that we can all work together to try and keep our patients therapeutic. We provide ongoing education to patients and their whānau. We have a shared care ability across DHBs, which means that we have really good networks and for the nursing services around the country. So if our patients are heading through to school at ADHB but they domicile in counties, we share that care, or if they're going down to visit Nan down in Hawke's Bay, then we can tee up that care with them down in with the team down in Hawke's Bay as well. So we have really good relationships. We provide patient support, we help navigate the health pathways, and we advocate for our patients. We provide holistic care and support to other services such as healthy homes, which is really important, as we've already discussed, social worker involvement and cultural input if required. And if there is a need for the benzathine injection to be given from a GP practice, then an example of that may be that somebody's come from overseas and they've come to you and said that they've had bicyclin in an overseas country or another DHB, and they require their benzathine, you can actually give them their injection, and the best practice is the ventrogluteal area, so that there's less nerve endings, less large blood vessels, so it's a little bit more comfortable for the patients to have, which is why we'd recommend that site. There is information in their Ministry of Health website that guides you through mixing lidocaine, which also helps with pain and discomfort, and the buzzy that provides a vibration that detracts from the nerve ending. So there are things that we can do to help, especially our young ones, to have these injections. So it might be worthwhile looking at that site at some point if you're not familiar with that.
Okay, so how to refer. So as Belinda said, sometimes you might get a patient that's come from either another DHB or that they've come from another country, and they've said to you that, that they've got a history of rheumatic fever. There's a health pathways, which we'll show you a bit later, but on the Auckland health pathways, regional pathways, there's a link that takes you to the community nursing link. Otherwise, if you're around the country, you can just send that through to the district nurse service usually, or the public health service, to refer that patient to start their bicillin. The important thing with referring is that you give us as much information as you can, and also that usually if we haven't had a bicillin done in New Zealand, so if it's been done overseas, we would like the first benzathine penicillin done in the GP practice, because otherwise we need to bring them into hospital just to have their first one. So usually we quite often, maybe the GP will do the first one and then refer to our community nursing, but we're very, very happy to take on that patient and look after them for you. Also, when you are referring them to the district nurse or the public health service to start their bicillin program, we'd also really like you to refer your patient for a medical consultation. So if they're a definite heart patient, they've got rheumatic heart disease, then you can refer them to the cardiology department. And if they're a rheumatic fever patient, but with no carditis, if you know that, then you can refer them to the infectious diseases. But if you're not sure, just send them to either is fine, and we will triage it anyway and put it through to the right department. If you get a patient that's come in and you've seen Nigel Wilson's presentation and you think, oh, maybe this might be rheumatic fever, please just send the patient in immediately for assessment, because we can do the echoes, the ECGs, all the blood tests, and it is a complex disease to diagnose, so it's really great to get that person in, that child in, just so we can do all the right tests. So I think I've covered, so yeah, if it's known heart disease, please refer to DHB cardiology. That's really, really important that, that we get them a review. And if you've got a patient who's come in and they've got rheumatic heart disease and they've become pregnant, please always refer them to your DHB under the high-risk maternity team for review. So this is the Auckland Health pathways, so it just shows you where to find it. It's actually a bit tricky to find, I think, but as you go into child and youth health, so even if you have an adult, you can still go and find this information. So child and youth health, then you go to medical, and then from there you have a drop down which is rheumatic fever, and that has all the information about the criteria. It also, if it further down, it goes around how to refer a patient for bicillin and lots of other information as well. And this is really important slide. We put this up because patients who have rheumatic heart disease, they really need to be seen regularly in our cardiology department, but also ones that have mild disease, we like to review them in the infectious diseases. But for patients with rheumatic heart disease, that's medium to high risk, moderate or severe disease, they should be seen 6 to 12 monthly by a cardiologist. So if you have a person who's come in and they've maybe been lost to follow up, or they've been at another DHB and they've come to you, please always refer them. We're really happy to see them and keep an eye on them, because that's very, very important that they have regular follow-up.
Thanks, Marianne and Belinda. So for the next part of this webinar session, we'll move on to a pre-recorded talk by our colleague, Dr. Simon Briggs, an infectious diseases physician at Auckland City Hospital. He is going to present the case of a young adult who's had a recurrence of rheumatic fever in their young adult years, which really highlights what can happen and go wrong if benzathine delivery and structured care planning perhaps doesn't go according to our best practice guidelines.
Good evening, everybody. My name is Simon Briggs. I'm one of the adult infectious disease physicians at Auckland Hospital, and tonight I'd like to talk to you about recurrent rheumatic fever, and I've also got a slide about the routine monitoring of people after finishing benzathine penicillin prophylaxis. So I'd like to start with an illustrative case. This is a 23-year-old Samoan man. He developed acute rheumatic fever at the age of 9. At that time, his major criterion was carditis with both mitral and tricuspid valve involvement. His minor criteria were migratory polyarthralgia and raised inflammatory markers, and his streptococcal titers were both above the upper limit of what is considered the normal range in New Zealand. So he had one major criterion, 2 minor criteria, and evidence of preceding group A streptococcal infection. At that time, he started benzathine penicillin prophylaxis. Unfortunately, he moved schools in the middle of 2015 when he was aged 16 years, and his benzathine penicillin prophylaxis stopped. There is a quote in his notes that he was lost to the system. Approximately 6 months later, in January of 2016, when he was aged 17 years, he presented with a further episode of acute rheumatic fever, so a recurrence of his acute rheumatic fever. At that time, his major criteria were carditis and polyarthritis, and you can see there that he had new aortic valve involvement. His minor criterion was raised inflammatory markers, and he had 2 sets of streptococcal titers performed several weeks apart, and you can see there that there was a significant rise in both the ASOT and the anti-DNase B. So he had 2 major criteria, one minor criterion, and once again, evidence of a preceding group A streptococcal infection. He restarted benzathine penicillin prophylaxis, and the plan is for him to continue that for a further 10 years until 2026. So looking at the diagnostic criteria for a recurrent episode of acute rheumatic fever, we can see there that in the same way as an initial episode of acute rheumatic fever, if you have 2 major or 1 major and 2 minor criteria, then you qualify as an episode of recurrent acute rheumatic fever. In addition to that, there is a further diagnostic category where you're only required to have several minor criteria. And the reason for this is that it can be difficult to diagnose an episode of carditis in a patient who already has known rheumatic heart disease. So this further additional diagnostic criteria of several minor criteria can be used to make a diagnosis of recurrent acute rheumatic fever. Now, I'd like to share with you data from a study looking at rheumatic fever recurrences in New Zealand between 2010 and 2014. This data is from a study. The lead author is Adam Dennison. At the time, he was one of the Paediatric cardiology registrars at Starship. So these are all cases of acute rheumatic fever in New Zealand in this time period, and each case was reviewed very carefully by a physician with expertise in rheumatic fever. and classified either as an episode of initial acute rheumatic fever or recurrent acute rheumatic fever. Now, I'd like to be able to illustrate some of the data that was found in these three figures. Looking first at figure 2 on the left-hand side of the slide, you can see in red the number of people who presented with an initial episode of acute rheumatic fever in the various age bands. And then you can see in blue the people who presented with a recurrent episode of acute rheumatic fever in the various age bands. This gives us a recurrence rate of 7.2%. Looking more closely at the age that these recurrences were occurring, if we look at figure 1 in the top right-hand side of the slide, we can see that the median age of recurrence was almost 22 years, and that more than 4/5 of the recurrences occurred in those aged 16 years or older. And that most of the recurrences were occurring in people aged between 16 and 25 years of age. Where were these recurrences occurring? Well, if we look at figure 3 in the bottom right-hand corner of the slide, we can see that almost 3/4 of the recurrences occurred in the 3 Auckland DHBs. So the take-home messages from the study are that the risk of recurrent acute rheumatic fever increases with age, and it's highest in those aged between 21 and 25 years of age. In general, this results from a lower adherence to benzathine penicillin prophylaxis after people leave school, and to a much lesser extent includes those people where benzathine penicillin prophylaxis is planned to be stopped at the age of 21 years, and then the person subsequently develops a recurrence later. Obviously, the diagnosis of recurrent acute rheumatic fever shows system failure and should prompt increased wraparound care for both the person with rheumatic fever and their whānau. Now, here is a slide looking at the routine monitoring of people after they finish their benzathine penicillin prophylaxis. Obviously, because the person has already had rheumatic fever in the past, any subsequent sore throat that they might develop once they finish their benzathine penicillin prophylaxis should be treated as high risk, and empiric antibiotic treatment should be given, especially if the person is aged under 30 or even 40 years. If we look once again at this figure from the study I was just talking to you about, we can see here that most of the recurrences were occurring with people aged 21 to 30, and to a lesser extent from 31 to 40. So really anyone who has had previous rheumatic fever, finished their benzathine penicillin prophylaxis, and then presents with a sore throat up to the age of 40, in my opinion, I would be keen for them to receive empiric antibiotic treatment. Obviously, if a person has rheumatic heart disease, then they're going to require ongoing regular cardiology follow-up, and they will require endocarditis prophylaxis in all appropriate or for all appropriate dental procedures. There are a number of healthy lifestyle factors that should be focused upon, and obviously the people in the audience tonight are much more expert at focusing on these than I am. Thank you for your attention.
So thank you. That talk from Simon Briggs, I think, really highlighted a number of pertinent learning points about rheumatic fever recurrence, and perhaps the care of young adults and adolescents presenting to primary care who may have had a past history of rheumatic fever and perhaps have become lost to the system or need extra support around their ongoing care management. In the last few minutes of the talk, we're now going to just talk a little bit about some of the useful resources that are available to primary care and secondary care clinicians alike in regards to rheumatic fever. This slide has links to a number of these useful resources. Just to pick out a couple for particular mention, the Heart Foundation guidelines you will have seen and heard discussed at several points throughout tonight's webinar session. We're delighted to be able to share that recently the Ministry of Health has agreed to fund a much needed update to these guidelines, and that this work will be starting within the next couple of months. We're really thrilled to have Dr. Annika Anderson from Te Kupenga Hauora Māori at the University of Auckland leading this process together with Associate Professor Wilson and myself, and this will be a chance for us to refresh the content of the guideline, but also to try and really reformat the guidelines so that they're in a very user-friendly, accessible, internet-based format for clinicians both in primary care and hospital settings. We are also hoping to develop a diagnostic calculator app so that if you're in the situation in primary care of seeing a child or young person with some symptoms suggestive of rheumatic fever, you can use that as a tool to aid the diagnostic process and guide referrals. So expect some news and wider engagement with primary care around that guideline update soon. Another really exciting development to share with you all is the resources that are on the Pumanawa Aotearoa ARF RHD network website. Pumanawa was formed in August 2019 following quite a period of lobbying and advocacy within the sector, recognising that we needed a national, I guess, one-stop shop or front door for the sector and researchers and community and whānau around all things rheumatic fever. And we were delighted that the NHC agreed to be the host agency with our co-chairs, Dr. Anderson and Dr. Malakai Alwhanoa. This network has had quite a busy work program since its inception. And on the website, which is freely accessible, you can see that it's beautifully laid out with lovely images, and there are really accessible resources for whānau and health professionals. And in terms of health professional guidance, links through to really a national repository of clinical guidelines and e-learning resources. This slide here just shows a small selection of what's available on the Pumanawa website. So I'd really encourage you all in your practices to go and have a look at this. So I think we're going to wrap up now and open up to the wider panel for questions and answers. Thank you all very much.
Kia ora, thank you so much to everybody for presenting tonight. It was extremely interesting. So we do have a few questions coming in, and if everyone wants to start asking more questions, please feel free, because now's the time. So to start off, I just have a question from a GP asking around recurrent throat pain illnesses. So they have a few Māori and Pacific youth with recurrent throat pain illnesses. Around more than 3 or 4 a year. They get negative COVID and strep swabs, and she gets requests to refer to ENT for tonsillectomy, and she's just wondering if they should consider doing strep serology titers rather than simply referring to ENT. Is there any value in doing strep throat titers in such a patient who are at high demographic risk with recurrent sore throat but negative throat swab results?
Thanks. I'm happy to start having a crack at that one. Interesting question. I think in the first instance, if there is a person in a high-risk demographic group, we should be following our National Heart Foundation guidelines around the approach to sore throat, and so continuing to swab if we can swab. And I understand, you know, in COVID times that isn't always feasible to get a bacterial throat swab, and we would treat with oral penicillin or once daily amoxicillin, either if you were treating presumptively without a swab or if you had a confirmed group A strep pharyngitis. I think the role of streptococcal antibody titers really comes in if you're suspecting that the person may have acute rheumatic fever. And so when a high-risk person is presenting with pharyngitis, clearly careful history around are there any joint symptoms or other major or minor manifestations, and a really careful cardiac examination as well. And please feel free to add comments, other panelists.
Yes, Nigel here. So I think that the short answer is no, you shouldn't do streptococcal titers. You're still going to rely on the throat swab. Most sore throats are still not strep. So you just got to rely on the throat swab. Yeah, it's not going to change your management doing strep titers in that situation.
Okay, thank you. Are there any funded dental care reviews for patients, as most of the patients that are affected are quintile 5, Māori, Pacific Island?
So that's a great question, and I might actually defer to Belinda and Marianne on that one, if you don't mind, ladies, because they've done a huge amount of work in our respective DHBs in Auckland advocating for dental care for patients, and are involved in some projects around this issue.
I could start with just purely from an Auckland DHB. So we have a couple of things. One is we run a clinic once a month. It's a rheumatic fever and rheumatic heart disease clinic, and we have our dentists that do help us with that clinic. So all our patients that are seen by the doctors will also be seen by the dentist, and as a free service. So that's excellent. But of course, that's a very small part of the population that we get to see on a regular basis. And we want them to have annual reviews at least. So we also have started, well, waiting to start, but very shortly, a dental project, which is run through a community dentist. So it's a private dental group. And it's for our moderate to severe rheumatic heart disease patients, and we're going to fund that. So we're going to send them to the community dentist, but we're going to manage it with regards to the criteria, and we'll pay for whatever restorative work that needs to be done, or just if it needs a checkup. That's only going to be a pilot program to see how well that runs, but I think it will be very successful and busy. And so the other thing is, if we do have a rheumatic heart disease patient who comes into hospital that is needs to be seen for other things, usually a cardiac, we will try and get them to see a dentist while they're in the hospital. But of course, if they do have moderate to severe rheumatic heart disease and they have an acute problem and they let you know, then we will quite often be able to see them through the hospital dental service. And that's just for Auckland DHB. So, but if you're very worried and a patient can't afford the care and you're worried about it, they could just go straight to ED or do a referral to the hospital dental service.
And from a county's Manukau point of view, there is the Auckland Dental School, which is based at Manukau Super Clinic or behind it. And they have fifth-year dental students that are supervised by, obviously, professional dentists. And they can be, there is a high wait list, unfortunately, but with free medical, it's a free service with a medical referral, so they can be referred there. So that was typically more the 18 years and over, because obviously under 18 medical dental care is free, but certainly there is that there is the ability in counties to do that as well.
Okay. Yeah, I do apologise for the fact that we do have clinicians from only Auckland at the moment, and I'm sure, as was mentioned, just to refer to your hospital dental services if needed. So with empiric antibiotic treatment for suspected recurrent sore throat, acute rheumatic fever, would you suggest waiting for the COVID swab result first before embarking on benzathine injection?
Rachel.
So there's a bit to unpack there, I think. I'm just going to try and share my screen again. So the Heart Foundation Sore Throat guideline is, I guess, what we would approach as stage 1. And then we also have a recurrent sore throat guideline that's embedded within the 2019 update of the Heart Foundation pharyngitis guidelines, specifically addressing the issue of recurrent pharyngitis. It's a really complex area. I think having a definition clear in our minds is important at the outset, and that is that the person has to have had 3 or more symptomatic episodes in 3 months. And then this algorithm takes us down an approach for either ongoing oral antibiotics or intramuscular benzathine penicillin. If they get oral antibiotics, ideally it should be directly observed. So that's, I guess, the approach to recurrent strep. I think tricky times at the moment with limited access to laboratory testing, and so I would tend, if someone presents with pharyngitis from a high-risk group, to do the COVID swab and start the presumptive antibiotics in the one visit. And in fact, some of our community COVID testing centres in counties Manukau, in particular at Druce's Road, took that approach last year. I expect that with the Omicron situation in weeks to come, we'll have very limited, if not no, access to lab testing. So we just need to take a pragmatic approach.
What would you recommend is the best way to transfer a patient from paediatric to adult department so that we don't have this loss to follow up attached to their name or unable to follow up?
Look, that's an excellent question. I guess within our own hospital outpatient systems, there's slightly different approaches in each DHB, but always due to patient and family mobility between DHBs and regions, there are people who slip through the cracks. Certainly at ADHB, we have an internal process where we would refer paediatric age group patients to a young adult clinic that Marianne, Dr. Miriam Wheeler and Simon Briggs run on a monthly basis to try and maintain engagement in care. And at Counties Manukau, we're fortunate that our combined rheumatic fever, rheumatic heart disease clinic is an all ages clinic to try and minimise that loss to follow up. But I think for primary care providers, if you've got someone in front of you that hasn't been seen for a period of time, just refer them in using Health Pathways as your guide to the referral process. And through the e-referral system, we'll quickly, the people triaging the referrals will quickly see if they're engaged in care or not.
Okay.
I think the e-referrals is really going to help a lot, because a doctor to doctor, the old fashioned way of doing it, I think that didn't work a lot of the times because a bit of paper got lost. And so I think as general practitioners, you can play a big role here if you see, as Rachel says, if you see anyone who's missed a follow-up. But I'm more optimistic for the future that going from children to adults with a child with a significant heart disease will be better from the health professional side.
Thank you, Nigel and Rachel. Just a little touch back on COVID here. So can patients with a history of rheumatic heart disease or carditis, do they have any contraindications for receiving the mRNA COVID vaccination?
So look, that's another great question. By and large, no. There is potentially an issue, and Nigel and Miriam, please feel free to jump in shortly, around people who've had very recent cardiac inflammatory illness and timing of the vaccine. But for the vast majority of our patients with ARF and RHD, the vaccination is felt to be safe. And here we go. So on the IMAC website, there is this guidance statement and some resources on kids' health. And then we've also got a wonderful resource in the form of a short YouTube video clip, not of the dog, but of Matt Johnson, who's a former Blues rugby player and secondary school teacher and patient advocate within our ADHB Rheumatic Fever Disease Management Group, and it's Matt, who's had 3 cardiac surgeries for RHD, sharing his experience and recommendations around the vaccine. So if you are looking after a patient with those concerns, you can look up those resources. Great, and I'm not sure, Miriam or Nigel, if you had additional commentary from your expert cardiac perspectives.
So there is a lot of fear around the vaccination, particularly in people who have had some form of cardiac history. But we do know that the risk of myocarditis from COVID itself is 30 to 40 times worse and associated with more severe disease. So absolutely, we encourage all of our patients to have the vaccine. Patients who've had a genuine myocarditis, and these numbers are very small, even if it's a non-COVID related, the timing needs to be sort of worked out based on sort of inflammation and things like that, and so delayed a little bit. But any form of sort of chronic heart disease absolutely should be vaccinated. We encourage it.
I agree with all that. We've had a lot of phone calls from families concerned about the myocarditis, and as you say, it's only the recent acute rheumatic fevers, but all the chronic rheumatic heart disease should have the COVID vaccine.
Thank you very much. Just a case-related question here. For someone who has been told to stop their benzathine injections by the specialist and then starts getting migratory joint pains again, would you recommend to restart them on the injections or re-refer to the specialists regarding this?
So I think they need a workup. As Simon said, it can be hard to tell whether a bit of moderate rheumatic heart disease has changed or not. So if you've got one minor, then if they had a temperature, if they had, so you would want the inflammatory markers and you would want the strep, and that's where they actually came from the World Health Organization. The 3 minors plus the strep is and because it's easier then. So I think the answer is you're going to be looking at that until proved otherwise, but you do need to run those tests.
Great, thanks, Nigel. So is dental prophylaxis recommended not only for those with a history of rheumatic heart disease, but those with a history of at least one episode of acute rheumatic fever?
Miriam?
I'd say any more than mild valvular heart disease would receive antibiotics if it's got completely normal valves. We haven't been.
Yeah, so it depends on the severity of the carditis, and also what we haven't emphasized so far is that if you have got mild carditis with your acute rheumatic fever, often that will resolve with good secondary prevention to nothing, and that's why you do the echo at 21 years. And so you're not, and I often say this to families, you've got mild or moderate involvement at presentation, but there's a good chance by 21 you'll have, it will be so minor that we'll actually stop penicillin. So the logic then is that you're not going to recommend dental prophylaxis for antibiotics for dental prophylaxis forever if they come off. But it's just, once the whānau understand that, then they can see the logic of it as well.
Perhaps just to chip in with an ID perspective, there's some global differences in opinion in antibiotic prophylaxis guidance between our practice guidelines in Australasia and the American Heart Association, and in the UK the NICE guidelines. But certainly our most recent iteration of the Cardiac Society and Australasian Society of ID guidelines definitely include RHD in the list of conditions for which prophylaxis is recommended. I think those guidelines were written in 2008, so I'm not sure if there are plans in progress to update those or not. But they are still available online.
And the American Heart Association valve management guidelines do state antibiotic prophylaxis for those at high risk of a complication from endocarditis. So that doesn't include the rheumatic heart disease population. So there is a bit of variation in the way things are worded internationally, but both Australia and New Zealand and the American valve guidelines support prophylaxis.
Okay. And is there a preferred antibiotic to give pre a dental procedure if the patient's already on monthly bicillin injections?
I'm happy to take that. And so some of you may have seen the National Heart Foundation little wallet cards for endocarditis prophylaxis for dental procedures. I think Marianne's just looking to grab one in her bag to show up. But essentially clindamycin or clarithromycin are our recommended antibiotics, and it can be a bit of a fiddle for the patient to get access to those anti-infectives prior to their dental work.
Oh, lovely.
Probably too small, I think. It's on the Heart Foundation. If they just type in endocarditis, it will bring up the actual guidelines in a table. That's very helpful. Just go into Heart.
Thank you very much. Do we have a national rheumatic heart disease registry?
Is Dr. Wilson still with us?
Yeah, certainly is. So we've been trying for many years and going back to Diane Lennon's days to get a national register of penicillin delivery, and the ministry are making more positive noises at the moment. We've also got a research-based rheumatic heart disease register, what we call a registry, and sadly we've got of moderate and severe disease nearly 5,000 individuals, of which 25% have died and over 60% have had operations. So and that data, if there is a national register about penicillin delivery, that the ministry know that the registry could be combined with that. And so that just sort of takes it back to the, when you have got moderate or severe disease, you have got rheumatic heart disease for life.
Thanks, Nigel. Just with the correlation between skin infection and rheumatic heart disease and acute rheumatic fever, are you wanting clinicians to be taking swabs of impetigo and things like that, or do we change our management of skin infection treatment just to reduce the chances of rheumatic heart disease and rheumatic fever?
Look, I think the potential association between skin infection and acute rheumatic fever and subsequent rheumatic heart disease is quite a complex area to unpick. Some of you in the audience tonight may have seen a recent paper from our colleagues at the University of Otago, Wellington, looking at this exact issue using large-scale administrative and population data. So that was Jane Oliver's paper in, I think, BMJ, either Public Health or Open. A complex area, I think, in terms of day-to-day primary care management of impetigo. Our current guidance actually still applies in that we should be using simple topical treatments initially rather than systemic antibiotics at this time. Colleagues here at the University of Auckland have recently conducted a randomised trial in counties Manukau and Kids program schools looking at the most appropriate topical treatment. So that's Dr. Sarah Primhack, Paediatric ID physician, and Emma Best from the Department of Paediatrics and our PID team at Starship. And so results from that trial will be disseminated publicly in the near future.
Awesome.
And a lot more work is needed to try and tease it out to actually inform patient management decisions. And it's clear that group A strep clearly is the bug that causes it all, but just the sequence of events is still, I think, not fully determined.
Awesome. Thank you for that. Just going back to the COVID vaccination, someone's just asked, with a patient newly diagnosed with carditis, do we wait 3 to 6 months until the inflammation is settled and then give the vaccine?
Yes.
Lovely, thank you. Just have a question from someone asking, changing someone to a 21-day bicillin program done, is changing someone to a 21-day bicillin program done if a recurrence of group A strep or a recurrence of rheumatic fever on the 28-day program?
That's certainly what happens if someone's had a confirmed or highly suspected recurrence episode. So they'd be moved from the standard 28 days to 21 days. We wouldn't necessarily do that for someone if they are having sore throat infections.
Okay. What's the typical time period between strep throat and the development of acute rheumatic fever?
Usually several weeks, but a history of a sore throat is not always, elicited in the patient when they present to hospital.
And we've got time for one more question. We're at our time limit now. So how much can we rely on patient age when we decide who to swab and who to treat with prophylaxis in group-based sore throat? For example, if the GP has a patient over 40 years with over 40 years old with a sore throat, is it worth doing a swab?
Look, I think that's a difficult question to answer. If the person has had a history of rheumatic fever or rheumatic heart disease, I would probably still be doing a swab. If they lived in a household with large numbers of children or any kind of family or household history of rheumatic fever, probably yes. But if there were no other demographic risk factors, probably not.
I think that's on the Heart Foundation.
Yeah, so utilising those health pathways sort of guidelines.
Yes, and back to the Heart Foundation guidance.
Lovely. Well, we've got one more question. Is every strep tonsillitis could cause rheumatic fever or not? And is it autoimmune? But could any strep tonsillitis cause rheumatic fever or not?
Yes, it could, but most don't. And it is autoimmune, and the pathogenesis, we're no further ahead, I believe, than we were 30 or 40 years ago. Other than the fact that skin is probably a reservoir as the throat is. But Rachel's, that's a simplistic heart view.
Very complicated and poorly understood.
Lovely. Well, that's all we have time for tonight. And I just want to say thank you again to everyone who's taken the time to present this evening and for those watching tonight. Thank you so much for everyone for joining us. So I just want to say, keep safe out there at the moment, everyone, and have a lovely night. Take care.
Bye.
Bye.